about the course. And remember, there are some lovely books to read about TMDs. First, of course, is Dr. Peter Dawson, Functional Occlusion from TMJ to Smile Design. And another gold standard is Jeffrey P. O'Cason, which is Temporomandibular Disorders and Occlusion. Another book that I find very simple and very relatable is the Manual of Temporomandibular Disorders, which is by Edward Wright. These three books, friends, are dedicated to occlusion and temporomandibular joint. And if you want to do more about full mouth reconstruction, smile designing, and things like that, please go ahead and check out Master Volume, which is available on mikdental.in or that contact. This book is also where Dr. Rajiv Chitkupi was kind enough to accept my invitation and has scripted a chapter where we talk about tooth and periodontal interface. If you want to know more about implant occlusion, how to manage a bruxer, how to determine the vertical dimension, how to treat a collapsed bite, how to do smile designing with veneers, all that, friends, is mentioned in the Master Volume. It's a complete clinical guide. No theory. Bahut theory pad liya humne. If you want an atlas, this is the book to refer. And if you are someone who's starting off in practice, there is also the starter volume, friends, that I have scripted, which is to do with crown and bridge dentistry. बेसिक्स में बेसिक्स, कौन सा मटेरियल कहाँ यूज करना है, शेड कैसे सेलेक्ट करना है, दांत कैसे प्रिपेयर करना है, कौन से बर्स यूज करने हैं, इंप्रेशंस के मटेरियल्स कौन से हैं, कौन से सीमेंट्स यूज करने हैं, and everything to do with basic crown and bridge dentistry is also mentioned in the starter volume. So feel free to go on to mikdental.in and you can get all the information you need there. And feel free to go ahead and follow me, friends, on different social media platforms. I am most active on Instagram. We are running short of time. I have overshot by 3 minutes. So we may not be able to answer all the questions you have, but if you wish to get answers to your queries, please send me messages on Instagram, and I would be more than glad to reply to you there. I have a dedicated channel on YouTube where we regularly update videos, more than 60 videos there, free of cost. Go ahead and watch them there. And of course, we have Facebook where you can connect with me. Guess what? I have also shared my email ID and I have shared my personal contact number. If need be, send me a WhatsApp and we could touch base there as well. At this point, let me thank you from the bottom of my heart for having graced this occasion, for sharing with me on this platform. A big thank you to the most adorable Dr. Rajiv Chitkupi for extending this invitation to me, and to ICPA for making this event happen. Once again, thank you very, very, very much. I now leave the house open for questions. Rajiv sir, if there are any.
There are many.
Marathon. I have gone non-stop. I don't remember the last time I spoke so many words in 30 minutes, sir.
I know. It was power packed and you covered so many things. And I understood one thing. Never say that there are no dental patients. There are a lot of dental patients, but they're in wrong clinics. They are not in dental clinics, they're in wrong clinics. So go around, meet ENT people, meet different people who are solving musculoskeletal problems, orthopedic surgeons. Tell everybody that if there is a case which you are not able to solve, chronic problems, chronic musculoskeletal problem, it could be a TMD issue, refer it back to us. We'll take a look at TMD and we can solve the problem. I think this is one big message that you gave, and that was very intriguing, how the entire cascade went down till the foot. And one more thing I understood was there are two levels to the problems. One is muscular level problem and the second is the joint level problem. And try to catch it early when it is at muscular level. You can you can prevent a lot of damage.
Perfect.
And so this is what I understood. And now let us come to the questions asked by the audience. They have sent it. They've been sending these questions for the last 7 days. Okay, there is one question. Do we need to deprogram the patient in every case?
No.
And okay.
No. Okay. So let's understand here. As long as the problem is muscular, deprogramming will help. And it will improve your patient's symptoms. But if it's already gone into a TMD, all right, which means the disc is displaced from its position, The moment you give the patient an anterior deprogrammer, believe me, 2 से 3 मिनट लगेगा पेशेंट की आंख से आंसू निकलना शुरू हो जाएंगे. Your patient's pain will worsen when you deprogram. That is your diagnosis. This is no longer a muscular problem. This is a true temporomandibular joint pathology. All right. So what I love to do in my practice is take a leaf gauge. All right. I hope you guys are aware of what a leaf gauge is. It's just strips of mylar on top of each other. Keep it between the midline, maxillary, and mandibular central incisor. Allow the patient to bite on this for the first 5 minutes. If the patient says my pain is worsening, please do not deprogram them. They are TMD patients. If my patient says pain bada nahi hai lekin pain kam bhi nahi hua hai, this is possibly a muscular patient, that is OMD. OMD you can treat left, right, and center. It's very easy to treat them. And guess what? 9 out of 10 patients who come in with orofacial pain will be OMD. One patient will be a TMD. That is where the permissive splint that I mentioned to you about comes in. Permissive splint goes by many names. You can call it Michigan splint, Ramford splint, SRS splint. बहुत नाम है. But एक ही शक्ल है उसकी. Flat at the back, small canine extensions, but in hard acrylic. So one takeaway that I want Rajiv sir for everyone to remember in their head is, please stop giving soft night guards for people who have clicking or are bruxing or clenching. You think you are doing good for them, but you're only giving them temporary solution, creating a bigger problem for them in the future. The sooner you spot these people, give them splints, hard splints. That's what they need.
Okay. So no soft splints, he will chew more and he will worsen the condition further. Okay, there was one question here, how to differentiate TMD and OMD, and you answered it very well. Most of the things are OMDs, and there is one TMD case, and that is where you have to differentiate from OMDs. So if you give a splint and it worsens, it is definitely a TMD. Otherwise, it will improve, and it is mostly an OMD case. All right.
Perfect.
So my question to see, there are a lot of youngsters who are watching this lecture, fresh practitioners. If you have to tell them one thing, okay, a patient has come to you and they are eager after this lecture to identify one symptom by which they can suspect that it is either an OMD or TMD, what do you want them to look for? There are a lot of things, like you spoke about Dawson, okay, Occasion and all. But for a young practitioner, if he has to suspect, what he should suspect by looking at?
Okay, so two things let me tell you here. First is your examination and second is history. पहले सबसे पहले पेशेंट को पूछो, ओके, जब पेशेंट जॉ ओपन करता है ना, इज द पेशेंट ओपनिंग स्ट्रेट और इज द पेशेंट डिविएटिंग द मैंडिबल टुवर्ड्स वन साइड? कई बार होता है ना, पेशेंट ओपन्स, जॉ गोज वन वे, और पेशेंट ओपन्स, जॉ गोज अनदर वे एंड देन कम्स बैक इन द मिडल अगेन. दिस इज टेलिंग यू कि डिस्क स्टेबल जगह पे नहीं है, ये टीएमडी है. If the jaw is not opening and closing smoothly, it has to be a joint related pathology, which means the disc is displaced. So that is your visual. If you hear clicking in the joint, tak tak sunai de raha hai, this is a TMD. Disc is already displaced from its position. Very important. Patient comes in saying mujhe yahan pe pain hai. All right. Patient points a finger to the joint. It's probably a TMD. If the patient says, "Doctor sahab, mujhe yahan dard hota hai," this is an OMD. 4 उंगलियों से अगर पेशेंट बताता है ना कि बड़े एरिया में है, तो दिस इज प्रोबेबली मस्कुलर. इफ द पेशेंट पॉइंट्स टू द जॉइंट विथ वन फिंगर, माय एक्सपीरियंस सेज दैट इज प्रोबेबली अ TMD.
Wonderful, great explanation, and it is making things very, very easy. And there is one question here from YouTube. Can we attach acrylic tooth in night guard?
Can we attach an acrylic tooth in a night guard? Now, what is the reason for giving that night guard? If that night guard is going to stabilize the joint in a patient where there are teeth missing, go ahead and do it. There is nothing stopping you, as long as you are recreating that balance in the occlusal scheme. No harm done. You can go ahead and give it. Why? Because remember, your splint is hard. It's acrylic. It undergoes polymerization. It's a resin. Your denture tooth is also a resin, so it will stick. अगर सॉफ्ट नाइट गार्ड दोगे तो सॉफ्ट नाइट गार्ड पे कुछ भी चिपका नहीं सकते हो. दैट्स अनदर ड्रॉबैक. इफ यू हैव एन edentulous space and if you want to make sure that one tooth is not going to super erupt. Super eruption is one of the primary causes for TMDs. Why? Because the moment there is super eruption, there is a disbalance in the joint in lateral excursion. So please go ahead and in your splint give a denture tooth if needed. Your denture tooth is going to serve two purposes. It's going to create function for that patient, and at the same time, it's going to stabilize the jaw in its musculoskeletally stable position. So feel free to go ahead and add a denture tooth if you believe it is going to improve the patient's function. No harm done.
Great. Okay, there is another question. What should be the thickness of permissible splint?
Beautiful question. Okay. Now there is no predetermined thickness in terms of anteriors. Why? Because कुछ patient को bite deep होती है, कुछ को shallow होती है, कुछ की open bite होती है. So that is why when we talk about splints, we talk typically in terms of minimum thickness at the terminal molar level. So imagine a patient who has sevens at the back. We typically say, let your permissive splint be 2 millimeters thick at the back. Two reasons. Why? One, 2 millimeter से कम होगा ना तो तुम्हें adjustment करने को जगह नहीं मिलेगी और splint will become excessively thin. You know what's going to happen over a period of time? As the patients bite on it, there's a possibility that the splint may crack, fracture, or even separate apart. And that tooth does not have the correct occlusal contact. So typically we say, if you're making this in a heat cure material or a milled material, 2 millimeters should be the ideal posterior separation. Typically, if you give 2 millimeter separation at the back, it equates to about 4 or 5 millimeter separation at the front. So अगर patient को 2 millimeter overbite है, तो basically 2 या 3 millimeter जितना splint patient का anteriorly दिखेगा. But splint इतना clear होता है कि patient को बाहर लोगों को पता नहीं चलता. And fortunate thing today is almost everyone is masked up. So literally no one knows that the patient is wearing a splint in the mouth. And patients get so accustomed to wearing the splint day in and day out, they don't even realize. अभी कैसा होता है मुझे पता नहीं मेरी घड़ी ऑन है कि नहीं है, because it's there all the time with me, right? So the same thing happens with the splint or chashma as a matter of fact. Right, Rajiv sir will be like, चश्मा पहना है नहीं पता नहीं चलता, पहना है बस पहना है. You don't even realize it's there because it becomes a part of your body.
Great. And I think there is a question here, and I guess it is related to the same thing which you answered just now. How do you identify the need, which case requires raising the vertical dimension and which doesn't when it comes to treating TMD?
Okay, so now very, very important point here is to help you understand that if a patient comes in with a temporomandibular joint disorder and needs a full mouth rehabilitation, you first stabilize the joint. You do not start with a reconstruction for a patient who has an unstable joint. Why? Because if the joint is unstable, the occlusion is never going to be stable. Because वो याद है complete denture में हम CR लेते थे, फिर CR change हो जाता था, फिर CR लेते थे, फिर CR change हो जाता था. It means आपका CR कभी सही नहीं था. CR means one stable condylar position. And if you have a patient who's a bruxer and broken the entire dentition down, he or she has broken it down because the joint is not stable. Bruxer क्या करता है? Mandible ऐसे ऐसे ले जाता है. It's a cow-like chewing habit, right? Or a buffalo bite. And this is only possible when the condyle goes in and out of the glenoid fossa. That's translation. Condyle is not keeping one stable position. So the first thing that you do is you start with a splint, not to check for your vertical dimension. कई बार लोग सोचते हैं स्प्लिंट देके मैं पहले चेक करूं वीडी बराबर है कि नहीं, पेशेंट को कंफर्टेबल है कि नहीं. The reason you give a splint is to allow the joint to go into a stable position. Once the joint is in a stable position, only then do you start with your full mouth reconstruction. And remember, when it comes to vertical dimension, don't go by freeway space. People usually raise the vertical on the basis अच्छा freeway space 5 millimeter है तो मैं 3 millimeter raise कर देता हूं. नहीं, freeway space constant नहीं होता है. Freeway space changes throughout life. It changes throughout the day. Morning, if you've slept and gotten up fresh, your freeway space will be more. In the evening, you're stressed, your freeway space decreases. So my belief here, friends, is whenever you're talking about vertical dimension, always gauge this on the basis of Silverman speaking space. 66. Your incisal edges should come close to each other but not crush into each other. They should not be too far apart. They should not be overlapping. That is the correct vertical dimension. Not freeway space, but Silverman speaking space. This is again something that I have scripted beautifully in the master volume, where there is an entire chapter dedicated on how to determine the vertical dimension, which cases to raise and which cases you don't have to raise. Now, the bite may seem completely collapsed, but guess what? There will be 7 out of 10 cases where you don't have to raise the vertical. And that concept is called re-establishing the VD, not raising the VD. And what that concept is, what is described beautifully in the vertical dimension chapter of the master volume, mikdental.in. You have it.
Very simple. Yes. Okay. So there is one question here. Is Facebook transfer and Centric record required for splint fabrication?
It is not. It is not. Remember, you determine the final vertical dimension of the splint intraorally itself. You don't need a FASPO. You don't need deprogramming. All right. You do it directly inside the patient's mouth, and then you fabricate the splint in what is called as comfort centric. Comfort centric is very similar to the patient's MIP. But now what you do is you keep adjusting the splint. Remember, patient is to wear that splint for 6 months. इसका ये मतलब नहीं कि तुम एक बार splint दे दो, काम हो गया, patient ठीक हो जाएगा, वैसे नहीं होता. The splint needs to be periodically adjusted as the condyle keeps going to its final stable position. All right. So you take the record in a comfortable MIP position, and then you keep adjusting the bite on the splint with the horseshoe-shaped 100 microns that I showed you, static with blue, dynamic with red, and typically it takes 3 to 5 appointments of adjustments. Okay, 3 से 5 appointment में condyle अपने centric relation position में चला जाता है, and typically हफ्ता 10 दिन के अंदर your patient will start sensing the relief in symptoms, provided they wear it 24 hours a day. I hope that answers the question.
Yes. And there are 2 questions. I think they are covered in this. What is the duration of splint therapy, and is it a permanent cure? And I think you have answered it beautifully. That we are, sequentially we are guiding the condyle to go in its normal position, and it takes 6 months where it progressively improves. If there is clicking sound but no pain, is there a need for any treatment?
Fantastic question, because this is a question, Rajiv sir, that has plagued me since the time I got into management of TMDs as well, and there is no common answer across the globe. Every system believes differently, and my belief is yes, treat that patient, but do not go ahead and treat it from a therapeutic perspective. Treat that patient from a preventive perspective, which means if the disc is displaced, patient has no pain, it's important to recognize that there is something that is causing the disc to displace. All right. Now, if the patient's stress levels increase, this patient is probably going to start clenching and grinding more. And that time, the disc may displace to an extent where it starts causing pain. Today, it is not causing pain, does not mean tomorrow there will be no pain. Clicking means ligament has been torn. As simple as that. So now you don't treat the pain, but you treat the cause. All right. So what I do typically for these patients is I design the splint and I tell them, don't wear it 24 hours a day, but wear it only at night time. Night is when maximum clenching and bruxism, maximum parafunction happens during sleep, right? So that's the time that you want to protect the system. So you tell the patient, wear this splint all your life, only and only at night time. And the patient like, sir, zindagi bhar kaise pehen sakta main? And I tell them, this is a disease. It is an arthritic form of breakdown. I give this example to the patient. अगर आपको डायबिटीज हुआ, ब्लड प्रेशर हुआ और डॉक्टर ने बोला ये दवा आपको जिंदगी भर खाना है, तो क्या जाके उसको सवाल पूछते हो, मैं दवा कैसे जिंदगी भर ले सकता हूं? नहीं पूछते ना, जरूरत है. Similarly, ये बढ़ता जाएगा. If you don't follow my instructions today, you will come back to me saying, sir, आपने 2 साल पहले बोला था, काश मैं तभी सुन लिया होता. ये मैं भविष्यवाणी करता हूं. And I always do this to the patient saying, it is your choice. My moral obligation is to educate you. My moral obligation is not to force treatment on you. That is your decision. God helps those who help themselves. Today, commit to it, and you will realize that you have evaded a problem. I often tell them, vaccine क्यों लेते हो? प्रॉब्लम है नहीं, बट वैक्सीन उसीलिए होता है ताकि पोटेंशियल प्रॉब्लम हमें हो ना. एंड दिस स्प्लिंट नाउ फ्रॉम ए प्रोफाइलैक्टिक पर्सपेक्टिव इज लाइक अ वैक्सीन, एंड दीज आर एक्चुअली थिंग्स दैट आई स्पीक टू माय पेशेंट अबाउट. एंड आई टेल देम कि वो हिंदी मूवी में डायलॉग होता है ना, काश थोड़ा पहले ले आते, हम इसे बचा सकते थे, वो नौबत नहीं चाहिए हमें. And I simply tell them right at the end, if you don't want surgery in the future, wear the splint today.
Great, absolutely great. And just to bring some lighter moments here, one of the dentists is saying, our relatives say that 5 साल में क्या पढ़ाई किया सिर्फ दांत के बारे में. No. After listening to the lecture, it appears like we are connected to so many diverse systems of the body. And one more good thing that I learned from your lecture was there is hardly any case that actually goes for TMJ surgery. If you combine the conservative modalities, multiple modalities, you can treat almost all cases in a very, very conservative manner.
Absolutely. Why? Because when it comes to open joint surgery, sir, the long-term prognosis is also not very favorable. So ऐसा नहीं है कि तुम सर्जरी कर लो ना तो प्रॉब्लम चली जाएगी, वैसा नहीं होता. And although I don't want to pinpoint, but कैसा होता है ना, as a surgeon, you always think surgery first. As a periodontist, you will think periodontal first. As a prosthodontist, I will think occlusion first. As an orthodontist, they will try to align teeth first. The thing here is we don't want to be tunnel vision. वो घोड़ा कैसे ऐसे लगा दिया तो बस वो सीधा ही जाने वाला है. We have to open our blinds. Just open the horizon. There's so much that you can do in this field. So it's important that we do interdisciplinary work. And don't just limit ourselves to how internship was. ये डिपार्टमेंट में सिर्फ ये करूंगा, ये डिपार्टमेंट में सिर्फ ये करूंगा. हम इंटर्न्स नहीं है यार. We are clinicians of the stomatognatic system. We are not just dentists. It's all about here. And they say ना एक आइडिया आपकी जिंदगी बदल सकती है. I'm hoping this night is memorable for you because it makes you realize that there is so much more that we as dentists can do. कौन बोलता है तुम डेंटिस्ट और डॉक्टर नहीं? हम भी फिजिशियन हैं.
Yes, so the message is build a team.
फिजिशियन में ऐसा नहीं होता है यार, ये सही नहीं.
Yes, so build a team, do it multidisciplinary, and keep it conservative. Absolutely. Okay, so I think there are a lot of compliments here, and I think this should be the last technical question. Can we give directive splints for disc displacement? If not, then it's an indication.
Absolutely. So if you have a patient who has a very loud click, right, and patient says कि डॉक्टर साहब 1-2 महीने से क्लिकिंग हो रही है, and if you can bring the patient to an edge-to-edge position, all right, and then allow the patient to open and close. In this position, if the patient says अब क्लिकिंग नहीं हो रही है, yes, you can give this patient a directive splint. A directive splint basically is a protrusive splint. So patient अगर यहाँ close करता है तो patient को आगे आके close करने दो. So as the condyle comes down, you may be able to capture the disc and hold it there. But what's important to realize about directive splints is हफ्ता 10 दिन, उससे ज्यादा नहीं दे सकते. If you give a directive splint to the patient for a longer period of time, fibrosis begins to develop within the joint space. अब तुम splint निकालो, patient को बोलो bite करो, patient ऐसे ही bite करेगा. Patient cannot go back to their usual closure, which is why what we do is we start with a directive splint, week 10 days, and we keep trimming and adjusting it down, and finally convert it into a permissive design, and now tell the patient wear it for 6 months. These are brilliant splints because we might be able to capture the disc and hold it in its final position, which is the best case scenario when it comes to long-term prognosis. You know what have you done? You have eliminated the click by stabilizing the disc on top of the condyle. Best case scenario.
Great. And actually I wanted to end it here, but there is one question which I think I should ask. Somebody is asking, is there a possibility that a child that has received a filling and there is a high point, a child will develop TMJ problems? And if at all it develops, how it is different from the ones that adults develop?
The problem is the same. बच्चा हो या adult हो, All right. Remember, a temporomandibular joint is a temporomandibular joint is a temporomandibular joint regardless of the cause. And most often that cause is iatrogenic. Most often हम जानबूझ के फीलिंग हाई नहीं छोड़ते, बट हमें पता ही नहीं था कि उसको एडजस्ट कैसे करना है या उसकी वजह से क्या implications हो सकती है. Okay, so just on a casual notes here, वो word था ना हमें idiopathic. Right?
Yes.
And we used to wonder कि idiopathic का meaning क्या होता है. Idiopathic का simple meaning है you are an idiot, your work is pathetic. Right? But that's purely on a lighter note. But remember, if you're leaving a feeling high or a crown high, think you may be creating a problem for the patient that he or she will suffer all lifelong, not knowing why did it happen. And I'm sure we as humble human beings do not want to go to sleep somewhere in the heart with this heavy feeling, I may have spoiled someone's life. My life changed that way, friends. Why? Because I treated a patient who came in with chronic headache. 6 years he was in pain. He had attempted to commit suicide twice. All right. He came in as a husband for some other patient that I was treating. And I landed up giving him a splint for trial and error basis. His life changed that very night. That very night. 6 साल का उसका माइग्रेन जीरो हो गया एक रात में. I could not believe what I had done. But when I sat back and tried to understand, I realized there are so many more who I can help. And here we are not talking about competing with someone saying, तेरा रूट कनाल 1500 है तो मैं 1400 करूंगा. नहीं करना यार ये. Remember, an eagle soars above everyone else. There's no competition up there. TMDs ज्यादा लोग नहीं करते हैं. My practice has changed completely. Why? Because Rajiv sir in introduction said, my practice is majorly full mouth rehabilitation, TMJ, and orthodontics based. Majorly means 95% of treatments. I will not have general fillings, root canals, pediatric patients coming in. Everything is referred and everything is smooth, organized, and synchronous. It's not like मैं दिन में 25 पेशेंट करता हूँ. थक जाएगा इंसान यार. तुम 10 पेशेंट करो लेकिन अच्छे से करो. And find satisfaction in what you do, because life is more than just earning money. It's about creating a balance and changing the lives of people, not just tooth pain, but brain pain.
Great. I think you have inspired a lot of fresh dentists or even the seasoned established people to look at this great world of TMJ. And the case that you told, 6 years of headache and overnight, I think that was life changing. It was life transforming
It was my
experience.
life changing, sir. Forget him. It was my life changing.
Yes.
It changed my वो दिमाग की बत्ती खुल गई. मेरी Mentos moment था मेरे लिए वो.
Yes. So I urge everybody, if you are looking for one niche area where you want to develop yourself and your practice, TMJ is a big world, and I suggest you can watch this lecture again. Moise has given such beautiful tips and he has actually taken some things at great depth. There is so much to learn from this, and you have actually solved many ground level problems that happen in daily practice. And if you want more knowledge from Moise, he has given you his personal number, his website, his courses are available, his beautifully written books are available. You are most welcome, recommended to make use of all these great resources. So that brings us to the end of this third episode of ICPA Clinical Series. I thank Moise from the bottom of my heart for giving his valuable time and making this whole thing so elaborate and at the same time making it so simplified. Okay, so ICPA Clinical Series is all about each episode one clinical challenge, and we thought TMJ should be the issue that we should deal with, and Moise has done complete justice to this one, what you can say, very complex problem and what he is known for. And thank you so much. And people who have missed the early, who joined late, you are always welcome to go back to YouTube, ICPA YouTube channel, ICPA Facebook page. You can watch it there. And in 1 or 2 days, we'll be putting a simple 5-point summary of this lecture. You can keep it with you. And if you are on WhatsApp groups, these messages circulate everywhere. Moise is here. Messages of Moise, they get circulated everywhere, all on Facebook. So I don't think you are going to miss the summary or the links of the recorded lecture. So I think we have just completed 1 hour, and I'm so happy that this session went so smoothly. I thank Moise once again. and I'm very curious to come and see how your TMJ setup is done. And I have not come to your center. I'm looking forward to the visit.
Look forward to hosting you, sir.
Thank you, everybody, and meet you again next time in another 2 or 3 weeks. ICPA Clinical Series 4th episode. You will get to hear about it more on the social media very soon. Thank you. Good night.